EMPACT-MI, Ultimate DAT PT, Clear Synergy. Feeling a little bombarded by all these trial names? I get it. Keeping up with the latest in heart health research can feel like trying to drink from a fire hose sometimes.
It's like a constant deluge of new information, especially in cardiology.
Absolutely. But don't worry, we're here to help you navigate these complex waters. What if I told you we could distill all that research, all those trials and guidelines, into the absolute most important takeaways, the insights that really matter for your practice? That's exactly what we're doing today. Think of this as your cheat sheet for understanding the most impactful developments in cardiovascular care.
Our goal is to cut through the noise and bring you clarity on what's truly new and potentially practice-changing in cardiology. We'll be looking at the most recent clinical trials and guideline updates, extracting the key insights and explaining why they matter.
And before we dive in, a huge thank you to London Heartbeat Z Academy UK for their ongoing support of this deep dive. If you're looking to expand your cardiology knowledge, definitely check out their website. They have over 150 fantastic courses, and you can follow them on Facebook, Instagram, and YouTube for free regular updates, and to stay tuned for more in-depth discussions like this one. Okay, are you ready to get started?
Absolutely, let's dive in.
Let's start with acute coronary syndrome, or ACS.
Right, and we have to start with the 2025 guidelines for managing patients with ACS. These are hot off the press, released just last month in February by the ACC, AHA, ACP, NAEMSP, and SCAI.
Those are the American College of Cardiology, the American Heart Association, the American College of Emergency Physicians, the National Association of EMS Physicians, and the Society for Cardiovascular Angiography and Interventions, just in case you were wondering.
Precisely. Now, these guidelines represent the most up-to-date consensus on how to best manage those critical situations when someone is having a heart attack or unstable angina. They've incorporated the findings from an incredible amount of recent research.
Speaking of research, I'm looking at this list of recent clinical trials related to ACS, and it's mind-boggling. There are so many acronyms. PREVENT, EMPACT-MI, Ultimate DAPT, DAPT-MI, Renovate Complex, Senior RETA, Clear Synergy. The list goes on and on.
It's a testament to how much effort is being poured into improving the care of patients with ACS. Every year, researchers are investigating new medications, comparing different treatment approaches, and focusing on specific subsets of patients.
And it's not just a few trials, it's a flood. Full Revasc, Fire, BioVasc, Multistar AMI, Flower AMAM, FRAMI-AMI, Stream 2. I'm getting lost in this alphabet soup.
Don't worry, we're not going to dissect every single trial. That would take hours. But I want to highlight a few key themes that are emerging from all this research, particularly focusing on where these trials are likely to have shaped the 2025 guidelines.
Sounds good. Let's start with ACS in patients with multivessel disease. That means they have blockages in more than just the artery that's causing the acute problem. What's the latest thinking on how to approach these patients?
Well, this is a very important question because a good number of patients who have an acute coronary syndrome actually have blockages in multiple arteries. So do we treat just the culprit lesion, the one that's causing the immediate problem, or do we go after all the significant blockages? That's the big debate.
And these recent trials, like Full Revasc 2024 and Senior RITA 2024, we're looking at exactly this issue.
Right. Full revasc CS likely compared complete revascularization, meaning treating all the narrowed arteries, to just treating the culprit lesion. And Senior RITA, well, the clue is in the name.
Senior RITA, right? It probably focused on older patients.
Exactly. It looked at different revascularization strategies, specifically in elderly patients who came in with a non-ST elevation MI and also had multivessel disease. And you'll notice that some of these trials are labeled as positive or negative.
Yeah, I see that. Like the FIRE trial 2023, which focused on FFR guidance, is labeled as negative.
Right. So the FIRE trial looked at whether using fractional flow reserve, or FFR, to decide which additional blockages to treat, those that weren't the immediate cause of the heart attack, made a difference in outcomes for patients over 75. And in this case, it seems that the answer was no. Using FFR didn't improve outcomes in this group.
So negative in this context means that the strategy being tested didn't show a clear advantage over the standard approach.
Exactly. And this kind of finding has real-world implications. It will likely inform the upcoming guidelines for PCI and multivessel disease, the 2025 GL-PCI MBD.
So these trials are directly shaping how cardiologists will be managing patients with more complex coronary artery disease. Makes sense. Now, what about intracoronary imaging? I see a lot of buzz around that lately.
Yeah, intracoronary imaging, particularly IVUS or intravascular ultrasound and OCT or optical coherence tomography, is a powerful tool. It basically gives us a much clearer picture of what's going on inside the arteries compared to just using standard angiography.
It's like having a high-definition map of the coronary arteries, right?
It's even better than that. We can see the different layers of the vessel wall, identify plaque erosion, visualize thrombus or blood clots, characterize calcium deposits, and even assess microvascular disease.
And this extra information isn't just for show. It actually helps guide PCI procedures and optimize how stents are deployed.
Absolutely, and we have solid evidence for that now. Trials like Illumian, Fourth, Optimal PCI, October, and Octivus have all demonstrated the incremental value of using intracoronary imaging, particularly in complex PCI cases.
So it's not just about getting a prettier picture. It translates into real benefits for patients.
Exactly. Better imaging can lead to better stent placement, better expansion, and a lower risk of complications down the line. Okay, let's shift gears a little bit and talk about medications, specifically aspirin. We see this provocative question here. Bye, baby aspirin.
Aspirin has been a mainstay of cardiovascular prevention for decades. What's changing?
The key point here is the distinction between primary prevention and secondary prevention. For people who have already had a heart attack or stroke or who have known coronary artery disease, aspirin remains crucial for preventing further events. But for people who haven't had a cardiovascular event and don't have high risk factors, the benefit of daily low-dose aspirin is much less clear.
So the risk of bleeding, even with low-dose aspirin, might outweigh the potential benefit for those who are at relatively low risk.
That's the current thinking, and the ACC actually came out with a statement back in 2018 recommending against routine aspirin use for primary prevention in most adults. The focus has shifted to a more individualized approach based on each person's specific risk factors.
And what about DAPT, dual antiplatelet therapy, after someone gets a stent? Traditionally, patients have been on aspirin plus another antiplatelet drug for quite a while, often a year or more. Is that changing?
There is definitely a trend toward potentially shorter durations of DAPT in certain patients.
So instead of a year, maybe just a few months.
Possibly. The rationale is to find a better balance between preventing stent thrombosis and subsequent heart attacks, which is what DAPT is good at, and minimizing the risk of bleeding, which increases the longer you're on two antiplatelet drugs.
And trials like TICO, Twilight, and TPAS have been investigating whether shorter DAPT regimens are as effective as the longer ones in preventing ischemic events while also reducing bleeding complications.
Exactly. These trials are providing the evidence that will guide the upcoming 2025 guidelines for antiplatelet therapy, the 2025 GL-APT. It'll be interesting to see how they incorporate these findings.
I'm also seeing some questions about other medications like colchicine and spironolactone. I see Colcott and Lodoco mentioned, along with a question about colchicine trials, and then Clear Synergy 2024 listed as a negative trial involving clear spironolactone.
Right, so colchicine is an anti-inflammatory drug that has been shown to potentially reduce cardiovascular events. Colcott and Lodoco were trials looking at colchicine in patients with stable coronary artery disease and after a heart attack, respectively. So the question here seems to be whether the new antiplatelet guidelines will address the potential role of colchicine as an add-on therapy.
And Clear Synergy investigated whether adding spironolactone and MRA, or mineralocorticoid receptor antagonist, to standard therapy after PCI for ACS would improve outcomes. And it seems the answer was no, hence the negative label.
That's right. And then there's a mention of Orbita 1 from 2017, Orbita 2 from 2022, and Reduce AMET 2024. Orbita, of course, was the trial that caused quite a stir because it questioned the benefit of stents for stable angina based on symptom relief.
That trial definitely got people talking. But how does it relate to this discussion on antiplatelet therapy and acute coronary syndromes?
Well, Orbita, while not directly focused on ACS, reminds us that we need to be very careful in interpreting clinical trial results and that the placebo effect can be quite powerful even in interventional cardiology. And Reduce AMI probably provides additional data on optimizing care after a heart attack, which could influence decisions about antiplatelet therapy.
Okay, moving on. I see ABC's Trial 2024 mentioned here, but without much context. Do we know anything about this trial?
Unfortunately, no. Our materials don't provide any specifics about the ABS trial. It's just listed as a recent trial.
Fair enough. What about Revive BCS2 2024? It's listed under ischemic cardiomyopathy.
Ah, yes. Revived BCS2. This trial likely investigated a new treatment strategy for patients with ischemic cardiomyopathy. That's the condition where the heart muscle becomes weak and damaged because of reduced blood flow, often from previous heart attacks or chronic coronary artery disease. This is a tough condition to treat, so any new insights are welcome.
Absolutely. Speaking of challenging areas, let's talk about vulnerable plaque. Those are the nasty cholesterol deposits in the arteries that are prone to rupturing and causing a heart attack. How are we getting better at identifying these ticking time bombs?
Well, we have several sophisticated intracoronary imaging techniques at our disposal now. IVUS can measure things like the minimal luminal area and the overall plaque burden. OCT is particularly good at spotting thin cap fibrothromas or TCFAs, which are a hallmark of vulnerable plaque.
Mhm.
And NIR, near infrared spectroscopy, can detect lipid-rich cores within plaques, which is another red flag.
So it's like having a whole arsenal of tools to assess plaque vulnerability.
Exactly. And each technique gives us a different piece of the puzzle. The more information we have, the better we can stratify patients and potentially intervene before plaque ruptures. And there's a reference here to Prevent 2024, published in The Lancet just last month. It probably has something to do with identifying vulnerable plaque, maybe a new imaging study or a trial of a new therapy aimed at stabilizing those dangerous plaques.
Now, let's talk about cholesterol. We all know statins are the cornerstone of LDL-lowering therapy. But there's a question here. Remember the Fourier trial from 2017? Why is that trial being brought up?
Fourier. That was a groundbreaking trial. It showed that adding a PCSK9 inhibitor to statin therapy could lower LDL cholesterol to incredibly low levels, and importantly, that doing so led to a significant reduction in major cardiovascular events. It basically opened the door for more aggressive lipid lowering in high-risk patients.
And since then, we've seen even more research in this area, with trials like Clear Outcome and Victorian Initiate 2024 further exploring the potential of these powerful non-statin agents.
And we're going to get even more guidance on using these newer therapies in the upcoming 2025 GL non-statin agents, so stay tuned for that.
This is exciting stuff. We're moving beyond just statins and into a new era of lipid management. What about managing other lipids like triglycerides and lipoprotein? Those are also important players in cardiovascular risk.
Absolutely. We now have icosapent ethyl, which is a highly purified form of EPA, an omega-3 fatty acid. The REDUCE-IE trial showed that it significantly lowered triglycerides and, more importantly, reduced the risk of cardiovascular events in patients with high triglycerides. There are questions here about the Strength Trial 2020 and the optimal dose of icosapent ethyl, suggesting that we're still refining how best to use this therapy.
And what about lipoprotein or LPA? That's a tricky one to lower.
Yeah.
Are there any new developments on that front?
There are, actually. For a long time, we haven't had effective medications to specifically target LPA. But now we have new agents like serlagerin, which was studied in the Alpicar trial, olaparib from the Oceana trial, and muvalaplin, investigated in the Kraken trial. These drugs work in different ways to lower LPA, and they've shown real promise. This could be a game changer for patients with high LPA who are at increased cardiovascular risk.
Amazing how quickly this field is evolving. Now let's switch gears again and talk about blood pressure. What's the latest on optimal blood pressure targets? We're seeing a reference to the Accord and Sprint trials, which were big studies that supported lower blood pressure targets in certain high-risk patients.
Those trials were definitely influential, but research continues to refine our understanding of optimal blood pressure targets for different patient populations. The recent BP Road Trial 2024 likely provides more insights into this important area.
And what about renal denervation? That
Uh-huh.
was a hot topic a few years ago, but then the enthusiasm waned a bit. Where do things stand now?
You're right, there was a lot of initial excitement around renal denervation, which is a procedure that aims to lower blood pressure by ablating nerves in the renal arteries. But some of the early trials, like Simplicity 3, had mixed results.
So people were a bit skeptical.
Yeah, understandably so. But the technology and techniques have been improving, and now we have newer trials like Radiance 2, Radiance HTN Solo, and Radiance HTN Trio showing more encouraging results, especially when patients are carefully selected. So renal denervation seems to be making a comeback as a potential option for patients with resistant hypertension who haven't responded to medications and lifestyle changes.
Fascinating. Now I see Cardia 2 2024 mentioned along with zilebesiran, which is described as using RNA interference. What's that all about?
Zilebesiran is a really interesting new drug. It's given as an injection and works by silencing the gene that produces angiotensinogen, which is a key protein in the pathway that regulates blood pressure. RNA interference is a cutting-edge approach to drug development, and zilebesiran represents a potential new way to achieve long-lasting blood pressure control with less frequent dosing. The Cardio-2 trial was likely designed to evaluate its efficacy and safety.
Okay, let's talk about heart failure. There's a question here about CFE iron and the AFFIRM trial. Why is intravenous iron important in heart failure?
It turns out that many patients with heart failure with reduced ejection fraction, or HFrEF, also have iron deficiency. And this can make their symptoms worse, limit their ability to exercise, and even lead to poorer outcomes. Several studies have shown that giving intravenous iron can improve symptoms, boost functional capacity, and reduce heart failure hospitalizations. The AFFIRM trial likely looked at this issue in a specific group of HFrEF patients.
And then we have the SGLT2 inhibitors, those amazing drugs that were initially developed for diabetes but have turned out to be rock stars in heart failure. We see Deliver 2022 and DAPA-MI 2023 mentioned here.
Yes, SGLT2 inhibitors have really revolutionized how we think about and treat heart failure. Deliver focused on dapagliflozin in patients with heart failure with preserved ejection fraction, or HFpEF, which is a type of heart failure that we haven't had great treatments for in the past. DAPA-MI looked at dapagliflozin in patients who had just had a heart attack, showing benefit even in that early post-MI period. These trials have expanded the use of SGLT2 inhibitors across a wider spectrum of cardiovascular disease.
And then we have the EMPACT-MI trial, which gets a more detailed breakdown here. What made this trial so noteworthy?
EMPACT-MI was a large trial that looked at empagliflozin, another SGLT2 inhibitor, in patients who were considered high risk after a heart attack. They were randomly assigned to either empagliflozin or a placebo on top of their standard care. And the trial had a long follow-up, almost 18 months on average. The goal was to see if empagliflozin could reduce their risk of dying or developing heart failure.
And the document actually lists the specific risk factors that made patients eligible for the trial.
Right, things like older age, reduced ejection fraction, prior heart attack, kidney problems, atrial fibrillation, diabetes, elevated biomarkers, high pulmonary artery pressure, incomplete revascularization, and extensive coronary or peripheral artery disease. These were patients who, despite surviving a heart attack, were still at high risk for future problems.
A very vulnerable group.
Absolutely. And the fact that the document simply states MPACT results without going into details suggests that the findings were pretty impressive. It's likely that empagliflozin significantly reduced the risk of heart failure and possibly death in these high-risk patients.
Now let's talk about another exciting class of drugs. GLP-1 agonists. We all know about semaglutide, which is marketed as Ozempic and Wegovy. But there are others like liraglutide and tirzepatide.
GLP-1 agonists are really making a splash in cardiology. They're already well established for treating type 2 diabetes and for weight management. But several large trials have also shown that they can reduce the risk of major adverse cardiovascular events in patients with high risk. And it seems like there's a lot more to come. We see 2024 and SURMOUNT-4 trial mentioned here, along with 2024 ESC.
ESC being the European Society of Cardiology Congress.
Precisely. So it sounds like there were some big presentations or publications on GLP-1 agonists at that meeting, possibly including new data on tirzepatide, which is given as a once-weekly injection. This is definitely an area to watch closely.
Okay, what about vericiguat? I'm seeing questions about the Victor and Valor trials.
Vericiguat is a newer drug that works in a unique way to improve heart function. It's been approved for use in patients with chronic heart failure with reduced ejection fraction who have recently had a worsening of their symptoms. The Victor and Valor trials likely investigated its effectiveness in different heart failure populations or scenarios.
And then there's a mention of Fine Arts 2024, which seems to be about MRAs or mineralocorticoid receptor antagonists. Those are drugs like spironolactone and eplerenone, which are commonly used in heart failure. What was Fine Arts looking at?
It probably evaluated a newer MRA or a different way of using these medications in patients with heart failure. MRAs block the effects of aldosterone, a hormone that can contribute to heart damage and heart failure. So the findings from Fine Arts would be relevant for refining how we use these drugs.
Now let's talk about hypertrophic cardiomyopathy, or HCM. We're seeing Valor HCM and Explore HCM mentioned, along with mavacamten.
Mavacamten is a really exciting new drug for HCM. It's the first in its class and works by targeting the heart muscle itself. Explore HCM showed that it could significantly improve symptoms and exercise capacity in patients with obstructive HCM. Valor HCM likely investigated its use in a specific context within HCM, maybe looking at its effects during exercise or in a particular group of patients.
And then we have Sequoia HCM from 2024, which studied aficamten. What's the story there?
Aficamten is another drug in the same class as mavacamten, also designed to target the heart muscle in HCM. The fact that peak oxygen uptake is highlighted suggests that the SEQUOIA trial showed a significant improvement in exercise capacity with aficamten. This further supports the potential of this type of drug for managing HCM.
Moving on to structural heart interventions, early TAVI is mentioned. That's transcatheter aortic valve implantation. It's a well-established procedure for severe aortic stenosis, but traditionally has been reserved for patients with symptoms. Is that changing?
There's definitely growing interest in using TAVI earlier in the course of aortic stenosis, even in patients who aren't experiencing symptoms yet. The rationale is that earlier intervention might prevent irreversible damage to the heart muscle and lead to better long-term outcomes. Trials like AVATAR, Recovery, and ALIGN-AR are investigating this very question.
So it could be a paradigm shift in how we manage severe aortic stenosis.
Absolutely.
And then we see Triluminate and Trisend mentioned along with Advent. What are those about?
Those are all trials focusing on specific areas within cardiology. Triluminate and Trisend are looking at transcatheter tricuspid valve repair. That's a minimally invasive procedure to fix a leaky tricuspid valve, which is a common problem in patients with advanced heart failure.
And Advent likely has something to do with atrial fibrillation.
Right. It's probably investigating a new ablation technique or a new drug strategy for managing AFib, the most common heart rhythm disorder.
And finally, we have NOAA-ALEB-NET6, which seems to be about those silent episodes of rapid atrial activity that are sometimes picked up by pacemakers and defibrillators.
Exactly. These episodes might meet the criteria for atrial fibrillation, but patients often don't even notice them. The question is whether these subclinical events, even if they're not causing symptoms, still increase the risk of stroke. The NOAH-AF-NET6 trial was likely designed to answer that question and to see if starting anticoagulation in these patients would make a difference.
Wow, we've covered a lot of ground. Before we wrap up, can we summarize the top 5 most important takeaways from all this research?
Okay, here are 5 key points to remember. First, the 2025 guidelines for managing acute coronary syndromes are out, incorporating the latest evidence from a huge number of trials. This is your go-to resource for staying up to date on the best practices for managing heart attacks and unstable angina. Second, we're seeing lots of research focused on the optimal way to revascularize patients who have an acute coronary syndrome and also have blockages in multiple arteries. The question of whether to treat just the culprit lesion or to go after all the significant blockages is still being debated, and trials like Full Revasc and Senior Rita are helping us figure that out. Third, intracoronary imaging, especially IVUS and OCT, is increasingly being recognized as a valuable tool for guiding PCI and optimizing stent deployment. Studies have shown that it can lead to better outcomes for patients, especially in complex cases. Fourth, the role of aspirin in primary prevention is being questioned. While it remains a cornerstone of therapy for people who have already had a heart attack or stroke, the benefit for those without existing cardiovascular disease is less clear, and the risk of bleeding might outweigh the benefit in some individuals. And fifth, we're entering a new era of lipid management with the advent of powerful non-statin agents like PCSK9 inhibitors. These drugs can lower LDL cholesterol to extremely low levels and have been shown to significantly reduce the risk of cardiovascular events. And there's a lot more research in the pipeline looking at these new therapies and how best to use them.
That's a great summary. It's incredible to see how much progress has been made in cardiovascular medicine, and it's exciting to think about what the future holds.
Absolutely. This is a dynamic and rapidly evolving field, and we're constantly learning more about how to best prevent and treat heart disease.
And that's what makes it so fascinating.
Definitely.
Well, this has been an incredibly informative deep dive. Thank you so much for sharing your expertise and insights.
My pleasure. It's been a great discussion.
And to our listeners, thank you for joining us. We hope you found this deep dive helpful and insightful. Don't forget to check out London Heartbeat's Z Academy for more great educational resources, and stay tuned for more in-depth discussions like this one in the future. And now, before you go, we want to leave you with a thought-provoking question. Considering the sheer volume of research and the nuances within each of these trials, how do you think the increasing complexity of cardiology guidelines will impact how we personalize patient care? How will it shape clinical decision-making in the years to come? We encourage you to reflect on this as you continue to learn and grow in your cardiology journey. Until next time.
Until next time.